Okay. What I wanted to share with you is my story about my husband, John, and his everyday battle with seizures. I'm going to give you a background of when this all started. Back in 1995, it was on a Tuesday that he developed flu-like symptoms, low-grade fever, generalized aches and pains. So I went to the doctor, they did some blood work. He said, you just have a case of the flu, nothing to worry about. If you feel better in 48 hours, you can return to work. So that's exactly what he did. He went in to work on a Friday. The next day, Saturday morning, around 10 a.m., he collapsed with a grand mal seizure. He was taken to the hospital, the emergency room, where they started Delanton IV and acyclovir on him. He was admitted to the ICU unit, and over the next 24 hours, the seizures became more intense, more severe. So the diagnosis was made of viral encephalitis. He also, from that point, became comatose for 4 days. When he woke up, John wasn't there. He didn't know who he was, where he was. He could not talk, and he could not walk. So after 10 days, he was transferred out of the ICU into a step-down unit and then transferred to JFK Neuroscience Institute for rehab in Edison. He was there as an inpatient for 3 weeks. Then he was discharged and became an outpatient 3 days a week. Over the course of the next 2 months, we noticed that he would have a lot of triggers from the right side of the head. If I walked up to him and spoke to him on the right side, he would have a seizure. If he was talking on the phone and using his right ear instead of the left, he would have a seizure. So our neurologist felt that what had happened is that the 8th cranial nerve had been damaged from the encephalitis, which is the acoustic nerve. So when you would approach him, or he would have a sound that close to his ear on the right side, it would trigger the seizure. So then we are now in January of 1996, and seizures again are becoming more severe, not really in control. At that point, he's on Delanton for the medication that they've given him. So our neurologist felt it was a good time to have him go up to Columbia in New York for a consult. So we went up there, and the first thing they did was they performed a PET scan. They wanted to look at the brain. And what they found, there was no lesions, no cysts, no tumors. You really couldn't see any damage from the encephalitis. There was slight brain atrophy, which would be normal. So what they proposed was that he was a good candidate for surgery. What they did back then at that time, this was 1996, they would do a double craniotomy. They would remove the skull, put the pads on the brain, place the skull back on, remove all his seizure medications, and allow him to seize, and they could do brain mapping. Then they would go back in at those focal points, and they would use a laser to zap those areas. And they would only go in once more if they needed to, because you have a 3-year window to do brain surgery. After 3 years, the brain is set. You're not going to be able to improve it by going in and trying to do a procedure. So that was what they had offered to do for him. But the thing was, he still would never be seizure-free. He would always be on a maintenance dose of Delanton, and he would never be able to drive. So John's question to them was, okay, this sounds great, but what is your success rate? The success rate was only 30%. So after about 3 weeks of thinking this over, he decided it wasn't worth the risk. He did not want to go for surgery. So he opted out of that option. At the time, they were running a drug trial up at Columbia, and John was accepted into the program. And I don't remember the name of the medication because it was never approved by the FDA. But it was manufactured in Europe, and it was mailed to our house. And John would take it according to the protocol that he was given. Unfortunately, after about 3 weeks of being on this medication, one night around 10 o'clock, he decided to go out our bedroom window, climb on the roof, and try to jump. Suicide. Suicidal thoughts. Luckily, I called 911. Everybody came. We were able to safely remove him from the roof, get him into the house, and we quickly, of course, stopped that medication. So There was no other drug trial at that time, so Columbia discharged us. There was nothing else that they could offer. So we came back to our neurologist here. So the next step was to try different medications that were available at that time. And the problem with the medications is it's all trial and error. You don't really know what's going to work. In other words, I can't say to you, I know Depakote is going to work for you. You don't. It depends on how the brain chemistry is going to react to the medication chemistry. So it's all trial and error. And the problem is this takes a very long time to do because every fourth day is when you change the dose of the medication. As you introduce the new medication and wean down the old medication, you have a very fine line there where the seizure threshold drops and they will have breakthrough seizures. John could not leave the house when we would be doing this because he would be having multiple seizures a day. So we first started off with Tegretol. And these are all very good medications. They do control seizures, but they have to work well for you. The Tegretol controlled his seizures, but unfortunately he developed a side effect. He became very anemic with the Tegretol. Now, John has dark olive skin, but he was pale, just like this countertop. His gums, his nail beds, his lips were very, very pale. He wasn't really able to function. He was extremely, extremely fatigued. So we had to discontinue the Tegretol. Next, we tried Topamax. Topamax didn't give him any side effects, but it also didn't control his seizures at all. So the next one we tried was Depakote. Now, Depakote, they've had huge success with children and teenagers with controlling seizures. But Depakote will cause severe muscle pain. And unfortunately, John did develop that also. He was unable to get out of bed. He couldn't function because he was in such agony with his muscles. And later on, I'm going to mention the muscle pain again because there's more to that. Neurontin was the next medication. Neurontin worked great. His seizures were in complete control, but he developed a Parkinson's-like syndrome. All right? His hands were shaking and quivering all the time to the point that he could not feed himself. So we had to come down off of Neurontin. Finally, here we are now. It's 1998. Now, we've been going through this now for 2 years because I said it takes a long time. 1998, our neurologist heard of a drug trial that was going to be up at Robert Wood Johnson. John went up. He was accepted into the program, and this was for trileptal. He's still taking trileptal. The reason is it only controls about 50% of his seizures, but he can tolerate it. He has minimal side effects from the trileptal. So it really works well for him. All right. Now, also we found with these medications, in the summer, he would have many, many more seizures, and we couldn't understand what was going on. And what it is that in the summer, when he was working outside in the yard or gardening, he was sweating a lot. And when you do that, your metabolism rate is up, so you're eating up the drugs. You're eating up that level. The level drops, you have a breakthrough seizure. Boom, he would have a seizure. He would come in from working outside, come in, have a glass of water, boom, down, grand mal seizure. And that's what it was. The drug level had dropped, so you had to be very careful with that. The medications put John into what I call a brain fog, okay? His cognitive skills are diminished. He has a very hard time remembering names. He has a very hard time balancing the checkbook. Simple things that we take for granted, it's a struggle for him. If I went home tonight and said to him, what did we have for dinner last night? He won't remember. He will not be able to remember that. Now, in a few days, he might recall that, but to say in 24 hours, what did we have the night before? He will not be able to recall. He won't be able to recall that. He describes it as it's like an open door is here, and he's trying to reach that open door. Just can't quite get to it. All right? He's like in slow motion. These drugs depress the brain so that you do not have the seizures. So this is how they feel. This is also why college students, teenagers, and young children are so difficult to control because they don't like taking these medications. All right? They like to skip a dose here and there, or they don't want to take it. And then you hear about how they'll have breakthrough seizures, and that's why, because they don't like the way these meds make them feel. They just don't feel themselves, right? And that's how he is. He describes it that way. He's just not quite himself. Their personality's different, the affect is different, and they just don't like feeling that way. Okay? We did try acupuncture and meditation and biofeedback, but it really didn't help in his situation. Now, the social scene, this is a tough one to get through. John has lost all of his friends, okay? And here's the reason why, and I don't blame any of these people. They don't want to take the risk of taking him out because you have two things you have to deal with. You have to deal with the initial seizure and what he goes through with the grand mals. And phase 2 is the postictal, okay? He wakes up, he's very confused, he has done some very crazy things, all right? So just picture this now. Imagine, you're out with him, okay? He falls with a grand mal seizure, okay? This is what it's going to be like, okay? He's lying here, okay? He's going to be on his back, all right? He's convulsing like this with his muscles, like this, making loud noises with his throat because his airway is closing, okay? He's chomping on his tongue and his lips and his cheeks, so blood is coming out of his mouth. Cheyne-Stokes respirations. He's very dusky, very diaphoretic, and he's always incontinent of urine. So whenever we go out, we always take a change of clothes because this is what is routine now for us. We expect this. So I don't blame people for not wanting to take the risk. It is a big risk to take him out because we never know when he's going to have a spell. There's no clue as to when or why it happens. So that's a big risk. And then you have the confusion state, the postictal state when he wakes up. Usually what happens with John, it's about 20 minutes after the initial seizure. What he will do is he realizes he's very wet. All right? His pants are soaked, his shirt is wet. So he immediately wants to take his clothes off and go to the bathroom. So that's a difficult thing to deal with because he wants to undress himself. Okay? No matter where you are, he's going to try to take his clothes off. So here's another good example of what it's like. We were out in a home improvement store. This was in the summer. It was in a hot July day. And we had completed our shopping, and we're at the cash register ready to, check out. Young college student was checking us out. And all of a sudden, for no apparent reason, John collapses with a grand mal seizure. Okay? So imagine now what I just described to you. Okay? What I did was I turned him to what we call the recovery position, put him on his side so he doesn't aspirate. And the reaction of the public, the reaction of everyone around me was, oh, I don't want to look at this. I don't want to look at this, Or I looked around me and some were, one of these. I don't want to see this, walking away from me. No one came around me at all. Some stood in horror, like way back, whispering to each other, what's going on with this? So the manager comes over to me and she says to me, what's going on? And I said, I took out my ID badge from the hospital. I said, I'm a registered nurse. This is my husband. He has seizure disorder. I can handle this. Don't call 911. Just give me some privacy and bring me some paper toweling. That's all I need. Do you think she listened to me? No. She calls 911. Now, this is a witnessed event. I witnessed it, and now I have lost control of the situation completely because she didn't understand. To her, he probably looked like a cardiac. Could be. A lot of people think that. They think he's having a massive MI when they first come up. So she calls 911. Everybody comes in. Okay, the first thing they do, slap an oxygen mask on his face, put him on a board, put a cervical collar on him, and they start an IV. And they can't get anything in his arms, if I told them. But they try. They can't get anything in his arms, so they finally get an IV in his foot. Okay? So we're going along with that. It's about 20 minutes into the seizure. And unfortunately, the young college student, she faints because she has never witnessed something like this. Now imagine what I described to you, how he looks. So now they go over and they put an IV in her. They give her some oxygen. So now we have two scenarios going on at once. So, I mean, I can't make this stuff up. This is really what it's like. So anyway, the next phase is what I had mentioned to you about postictal. Okay? So this is what happened. John wakes up very confused. First thing that happens, oxygen comes off, rips off the collar, rips out the IV, tries to sit up. Now this is where this muscle pain was coming in I was telling you about. When you have a grand mal seizure, the lactic acid is pouring through your muscles. So your muscles are extremely sore. Okay? They're very, very sore. They're very weak. So here now, this guy's very confused. He's trying to get up. He's swinging at everybody. Doesn't know what he's doing. He's swinging at everybody. He's yelling out. He's trying to get his pants off because he realizes he's wet. So I have to have 2 policemen there, and they're restraining him. So his adrenaline is pumped because he's angry and he's confused, and these guys are holding him down for his safety. It's always for his safety. So now his muscles are getting even more fatigued. So that's what I mean about this muscle, the muscle pain. When I do get him home, I have to get help getting him out of the car, and he goes to bed and he just sleeps for hours because he is totally exhausted. Okay? All right, so moving forward then, we get John up. Finally, police help me. We get him in the bathroom, get him changed, get him in the car. He's all settled. Okay, I go back to see how the young girl's doing. She's okay. I'm talking to her. I try to explain a few things. She's all right. It was just her first time to ever witness anything like this. So I'm up paying for my bill, and the store manager calls me over. Just come over here. I want to talk to you. I said, okay. She said, I have to tell you something. I don't want you to come back here ever again. You can come here and shop if you want, but don't bring your husband if he has this problem, because you have this huge commotion in my store. My employee has fainted, so I'm asking you, do not come back. Okay? So that's the attitude you have. And I said, excuse me? This is ridiculous. She said, no, sorry, you cannot come back here. You cannot back here. Do not come back. All right, so we didn't go back, obviously. Get John home, goes to bed. So here we are, it's year 2000, and he's very depressed because he can't go out. Nobody wants him out. If we have a problem, it's like people are disgusted, they ask us to leave. This also happened in a restaurant. They asked me to leave because he had had a seizure. So he's very depressed at this point, can't go out, has no friends. So he read an article in the paper about a woman who was 45 years old in St. Louis who had had a stroke, and it left her with seizure disorder. She was alone, so her friends encouraged her to get a dog. They said, why don't you get the dog for some companionship? She couldn't work, couldn't drive. So that's what she did. And then in this article, she wrote about how after a couple of years, the dog seemed to be able to tell her when she was going to have an aura. So John corresponded with her for a while, and she told him how great it was. She was back working part-time. She said when she would feel a seizure coming on, the dog would give her enough time. She could close the door to her office, lie down, get in a safe position, take her glasses off, and go through the seizure. She could take the city bus to and from work with the dog accompanying her. Okay? She couldn't drive, but she could certainly use the city bus going back and forth for her job. So John thought about this. So in 2001, he decided he would get a dog. And this is where he met Cloud. She was 10 months old at the time. And so they bonded very well. And the idea was to keep her with him as much as possible, because here's what happens. Prior to the aura, the brain sends out a chemical smell through the skin. We can't detect it. But a dog's sense of smell is 17,000 times greater than ours, and they can tell. So it took her a while, 2 to 3 years, before she really understood what was going on. But she would lie next to him when he would have a seizure. She was with him all the time because he was not working. So she finally kind of understood what was happening. And we noticed that what she would do is she would walk circles around John, or she would sort of lean against him, her whole body, just sort of lean against him, like telling him it's time for you to lie down. She gives him about a 45-second warning, which is enough time that he can get down in the safe position, take off his glasses, and he takes an Ativan sublingual. Okay? The reason for that is that prior to the aura, the brain gets very anxious. It's like, okay, here we go, another seizure's happening, I can't stop it. So it does help the brain become less anxious. And this is what the treatment was from Robert Wood Johnson, the epileptologist. They felt that the Ativan would help. And sometimes the seizures are not as severe because he does take the Ativan. And the thing for John, the big key here, is he doesn't fear his seizures anymore because he's never alone. He knows she'll be with him. She'll lie down next to him, she'll lick his hands, she'll lick his face, so he's never alone. So that fear is gone. Also, they take a 3-mile walk every morning. They're able to go out together, and I don't have to worry about it. If I'm with her, if I'm with them, that's fine. If I'm not, the local police, they know the situation, but the key is this. When we are out now shopping, and this scenario occurs, as I described to you in the store before, the public response is totally different. It's like a 360. They all come over to me. I'll look up, and there'll be people all around me. How can we help? We see you have a service dog. What's going on? Do you need us to call 911? And they will stay with me through the whole process. They don't run away. They will stay with me until I can get him up, get his clothes changed, and they will help me get him in the car. Sometimes they'll say to me, do you want us to follow you home? We'll help you get him out of the car when you reach your home, okay? Because of Cloud, okay? Because they see the dog, they realize this is a service dog, and they're not afraid. They're not so afraid of what they see. So it's really been fortunate for John to have the dog, and he's not able to work or drive, but he can enjoy life in other ways now because of her. So if you're out and you see someone having a seizure, please try to protect their dignity. You know, what other people, even though other people may respond differently, you know, and get them in the recovery position and just stay with them so that they're not alone. Okay, thank you.